Next, I'll invite up to the podium my friend and colleague, Dr. María Fernández. Maria is an associate professor at the University of Texas School of Public Health, where she's also associate director of the Prevention Research Center.
Okay, I'd like to thank the conference organizers. It's a pleasure to be here. I'm actually in Puerto Rico quite often because we have strong collaborations with the Cancer Center. I'm going to be talking today about leveraging systems for HPV vaccination, and I'm grateful to the presenters from the previous panel as well as some of them from this panel that you focused on developing countries, because I'm not going to do that. I'm going to highlight some systems in the United States and Puerto Rico, but that I think that some of the lessons learned from leveraging these systems can be applied to other countries as well. So I'm going to talk about community health centers, and in particular federally qualified health centers. I'm also going to talk about lay health education models, and then a non-traditional social service model, which is call centers. So I am going to focus on federally qualified health centers, which are types of community health centers, but I think that some of the lesson learned when we look at the factors that influence the adoption and implementation of cancer control programs, including HPV vaccination, can be applied to private or public hospitals, privately owned primary health clinics, rural health clinics, and other safety net clinics. Now, we know from the U.S. Community Preventive Services Task Force and that there are several evidence-based approaches recommended for increasing vaccination. And these include client reminder and recall systems, client-based education, and then other interventions to increase access to vaccination, such as reducing client out-of-pocket costs, and interventions directed at vaccinating at providers or systems, and those include provider reminders and provider assessment and feedback. The other ones that aren't highlighted that are listed here doesn't necessarily mean that they don't work. It just means that there's insufficient evidence to provide a strong recommendation. Those of you familiar with the U.S. Preventive Services Task Force know that these recommendations come from a systematic review of published studies that are grouped according to the type of intervention, and then recommendations are made both on the strength of the evidence as well as the quality of the studies. So quickly, there are community health center systems in other countries that are similar to FQHCs. Most developing countries make use of community health clinics for services that span chronic disease management, vaccination, and they're leveraged to provide comprehensive health care. Federally qualified health centers are community-based, patient-directed organizations. They receive federal funding, and they primarily serve medically underserved populations. So people who don't have insurance, they may be undocumented, those who really fall through the cracks in terms of receiving services through other organizations. So FQHCs, or community health centers, are located in high-need areas, high levels of poverty usually. They're open to all residents, regardless of insurance status. They typically tailor their services to fit the specific needs of their population, and they provide comprehensive primary health care. There's about over 1,000 FQHCs in the United States and Puerto Rico. And they serve largely racial and ethnic minorities, with 34% of their population being Hispanic Latino and 26% African American. They also primarily serve individuals with very low levels of income. So the current, why did I choose to highlight FQHCs? Well, there's a lot of changes going on, the current policy landscape that makes it a very interesting and timely system to look at, and in particular in trying to understand how these clinics are adopting and implementing and sustaining changes, practice changes to improve their cancer control and other chronic disease efforts. So some of those policy issues include the Affordable Health Care Act, patient-centered medical home movement, the meaningful use of electronic medical records, and uniform data system requirements. So all of these have contributed to this moment of change in federally qualified health centers where they're receiving more money, where they're being charged to do many more things. And this comes as a benefit to them in terms of the resources, but also a tremendous challenge in trying to do many things at once. And so as part of the Cancer Prevention and Control Research Network, which is a network of 10 centers around the country with community and primary care partnerships, we decided to form a work group focusing on FQHCs and conduct studies to better understand factors that influence the adoption and implementation of cancer control programs. So the rationale was if we understand those factors that influence, then we can better develop interventions to accelerate the adoption and implementation of such programs. So I'm going to be focusing on some of the findings from a qualitative study that was done. We're getting ready in a few weeks to roll out a national survey for these federally qualified health centers. So we did in-depth interviews and focus groups broadly informed by the Consolidated Framework for Implementation Research, which really looks at a number of factors that seem to influence the ability for organizations to adopt and implement practice changes. And we also used an appreciative inquiry approach. And for those of you who aren't familiar with that, it's when you go in and instead of talking about, well, what are the problems, what are the barriers, what do you see happening as you sort of adopt this evidence-based approach to increase vaccination, instead of that, you start with asking folks about what has really worked in the past. So what are some examples of practice changes that have occurred where there was great communication, leadership, where things have worked really well? And this was actually, although I've done a lot of qualitative research, this was the first time that I used this approach, and I was actually really impressed with the types of feedback that we got. So we collaborated in this study with the National Association of Community Health Centers and Primary Care Associations in the 10 states. We've analyzed the data. We're working on 2 manuscripts based on these findings. But what I'd like to point out here is just a few of the results that have, I think, important implications to enhance HPV vaccination. And one is the importance of FQHCs in attending to their patient needs by tailoring their services. So patient-oriented efforts to enhance HPV vaccination must take into account patient characteristics and including their priority problems and barriers. So there may be sort of a disconnect in terms of the initiative and the willingness to adopt practice changes if they're not seeing patients accepting the vaccine or interested in the vaccine. FQHCs are faced with competing priorities and limited time and resources, so provider-oriented efforts have to begin with buy-in from providers and integrated into the existing workflow. The integration of electronic health records in terms of monitoring performance, prompting providers to recommend vaccination is another critical issue, and very much in the minds of these FQHCs. And then certainly financial sustainability is a key factor for implementation. And for some of the FQHCs that are experiencing financial difficulties, the way that Vaccines for Children works at least in Texas, is that they have to have out-of-pocket expenses to purchase vaccine, and then they run the risk of actually losing money if that vaccine is not used. Okay, so I'm going to turn to another system, which is lay health workers and or community health worker programs. Now, you may know that community health worker programs have a long history and actually began in developing countries, of much more used in developing countries, and in those countries they're often trained as nurses and perform services including vaccination. And underserved and inaccessible communities, the ones that face the most barriers in terms of accessing care, are the ones that can benefit the most from lay health worker programs. Even in developing countries, those with high ratios of physicians to patients, these programs can be exceedingly helpful, and particularly for those who are underserved or disenfranchised because they don't have insurance or for what other reasons. In the United States, an estimated 1 in 5 individuals have inadequate or no access to primary health care, and community health worker interventions have been shown to improve this issue. So what do we know about the effectiveness of lay health worker programs? There's a Cochrane review that has shown that they've been effective in increasing immunization uptake, promoting breastfeeding, and other behaviors, and also increase in use of cancer screening tests. In some of my own studies, we've shown an effectiveness in lay health worker programs for increasing cervical cancer screening. Both the Cultivando la Salud program and the Amigas program showed the effectiveness of this type of program for increasing screening in Mexican American individuals. So the advantages are they help the healthcare system overcome barriers. As members of the community, health workers deliver messages in a culturally relevant manner and provide these interpersonal connections. They have the potential to address substantial disparities in care, and they can help disseminate widely efficacious interventions. However, there are several challenges, and we recently published a commentary in the American Journal of Public Health related to some of these issues. And some of them in terms of scale up and broad scale dissemination of these types of programs are that individual skills and training vary considerably. There's an assumption of shared culture, which in the United States is tricky, particularly when you're talking about Hispanics. So in a community, for example, like Los Angeles, where there are Hispanic individuals from a number of different countries, does it mean that you have to have a lay health worker from Mexico targeting Mexicans, from El Salvador targeting Salvadorans? So there's a lot of questions about what do we mean by shared culture? Not all program planners have a clear role for community health workers. The quality of the relationship, the interaction with the community can be affected by lots of differences in terms of what they're actually delivering. What are the products that they're using? I'm going to talk a little bit more about those communication strategies later today. But there's a lot of questions about that. And the evidence of effectiveness is mixed. I mean, it's not 100% clear that these programs work, and they work in all cases. And I think that that's something that we have to think really carefully about when we as scientists and activists have good experiences with programs like these. We tend to sometimes, I think, overemphasize their applicability, and I think that we have to be careful about that. So some of the remaining research questions include, does the intensity of interventions, who's delivering it, or the materials influence effectiveness? Is group lay health education and one-on-one education equally effective? What's the relative effectiveness and cost effectiveness of different types of lay health worker delivered small media? Can they effectively deliver interventions on multiple behaviors, and are tailored approaches more effective than untailored approaches? And these are what we call the known unknowns, but then there's a lot of unknown unknowns, right? So it's hard to ask a question when we don't know what we're supposed to be asking, right? And so what is it about lay health worker programs that contribute to their success? And I think that there's a lot of work that needs to be done in this area if we're ever going to be able to identify those core elements of lay health worker programs and increase their use. The last one, and I'm going to go really quickly on here because I realize I'm running out of time, is the use of a non-traditional system for increasing vaccination and screening. And the example I have is the 211 call system in the United States and Puerto Rico. And 211, like 411 for information or 911 for emergencies, is a nationally designated 3-digit helpline. In the United States, there are 187 call systems. 13 states have 100% coverage. Many other states have about 80% coverage. And people are calling this number for a variety of concerns, and I'll tell you what some of those are in just a minute. In Houston alone, we get 1,000 calls a day, and these calls come from people who are underserved, poor, and have multiple risk, cancer-related risk behaviors. So the primary goals of our study that now has gone on for 3 years, and we just got funding for another 3 years, is to assess the cancer prevention needs, provide referrals, and provide navigation to 211 callers from 23 Texas counties served by 211. And we're focusing on Houston, the Lower Rio Grande Valley, and El Paso, so areas of large Latino populations. And to determine the effectiveness and cost effectiveness, and also the budget impact of cancer control phone navigation compared to referral alone. So people are calling 211 for utilities. I can't pay my electric bill. They're confused about medical or prescriptions, or they have bills that they can't pay. Food is a big one, rent or mortgage, and shelter. And these 211 callers, call specialists answer the calls, and based on a large database of local services, connect people to available services in the area. In our study, we ask people if they're willing to answer some questions related to cancer risk. If they are, and they have an identified risk, and we found that at least about 80% of the people have at least one cancer-related behavior that they could receive services on to reduce their risk. Then they're randomized to either getting navigation or referral alone. So I can't give you the results yet, but I can tell you that colleagues in St. Louis are doing a similar study, and they're finding really good success in both navigation, and they're also using tailored print information to send callers to, and so they're seeing some big differences. So navigators provide referrals, answer questions, describe importance of an education on screenings, assist with appointments, and they provide these referrals, and I've just highlighted those ones related to cervical cancer there. As I mentioned, in our study, we're in Houston, Weslaco, and El Paso. We've conducted risk assessment on over 4,000 callers and enrolled about 1,300 in our study. Just a little bit on the demographics. The majority of callers are women. 90% of the callers are women. We have over 53% are Hispanic, and this is our Houston data, and very low levels of education, very low levels of insurance. So when we look at insurance across our 3 sites, we see quite a bit of variability. This is people with no insurance, so on the border, no surprise, much higher levels of no insurance. So these are 70 and 71% of people that have no insurance as compared to the Texas and the US. Not too bad on Pap Test screening within the last 3 years, and something good is happening in El Paso with 95% of the callers having had a recent Pap Test. When you look at vaccination in the Lower Rio Grande Valley, we have the lowest rates among women in the catch-up group between 18 and 26, and not too bad compared to the U.S., but still a long way to go to reach 100% coverage for HPV vaccination. So I wanted to highlight some of the lessons learned in working with a system like this to link people to services. And one is that the organizational culture is extremely important. And when you are trying to do research and health services to an organization that does not typically do this, there are some challenges. But so the importance of getting program champions within the organization is, can't be overestimated. So I think that there's some challenges for further investigation, including research in service-oriented environments, competing responsibilities, commitment of collaborators, implementation practices, quality control, and support and continuity. But I think that what this example does show is that there are existing systems out there that may not traditionally be involved in healthcare that could be leveraged to reach those populations that are in the greatest need. So I think one of the potential of this work, I think, goes far beyond using 211 as a recruitment venue for interventions to reach poor citizens. I think the big payoff is in helping an established service organization with broad reach in a disparities population use cancer control strategically. So 211 systems take an estimated 16 million calls annually with a potential of reaching 3.1 million women in need of Pap Test, 2.3 million needing the HPV vaccination, and 1.9 million with daughters in need of the vaccination. Thank you.